So this probably won't come as any surprise, but why do we actually need a chronic pain pathway? Why is this important? So I think everybody that is probably on this call either personally or have somebody in their life that is impacted by chronic pain. 1 in 5 people have chronic pain of some variety, right? So there's 2 ways that when this document was developed that we thought there was going to be value for. One for the patients and the other is for the providers. So for the patients, this is intended to act as a repository of patient self-care management resources that can be valuable for looking at different groups and services available throughout the province. It's meant to complement some other already existing projects such as SASK Pain. I'll give a shout out to SASK Pain, which is a nonprofit organization. So it's meant to complement some of the work that's been done in the province already. Now, the patient part of the pathway is still very much in development. You're going to hear this over and over. This is a living document. It's developing as we go. So definitely stay tuned for the patient resources that are going to continue to roll out. Now, for the providers, this is meant to give actual evidence-based management strategies for the treatment of chronic pain of your patients. It's meant to work as information. You want to know both how and when to access different specialty services. Now, this may or may not include pain clinics initially, right? So we want to start thinking about, okay, well, when is it appropriate to refer to a sleep medicine specialist or a neurologist or a spine surgeon, et cetera, et cetera. So again, complementing with things like spinal pathway, with efforts that have been made with other specialty services, and really trying to integrate different things that have been done in the province to date. So from that, let's start getting into the meat and potatoes. We're going to start with a case that's going to be presented by Dr. Sarah Liskowicz, and we're going to see how we can put this pathway into work here.
Perfect, thank you. So I want you to envision yourself like I am going to be in this case as a family doctor or a frontline prescriber out in the community, and this is where you meet Ed. I'm not at the chronic pain clinic. I'm out in the community, just like many of you. This patient is a common patient that you are generally meant to see in primary care. So Ed is an 87-year-old retired construction worker, and he has a long history of arthritis that really mostly affects his shoulders and knees. And he's having a lot of pain despite taking Tylenol and ibuprofen. He particularly has severe pain in his right and left knees. He's had total knee replacements already, and he had a very difficult post-operative course with marked pain and stiffness. And this is affecting not only his pain, but also his whole life. He has a negative effect on his sleep and depression due to his pain. He'd like to avoid further surgeries, given that he is 87 and has multiple other medical conditions. But his pain is causing marked limitation of activities, and he's asking for your help, what you can do for him as an outpatient prescriber. So I think it's important to understand what chronic pain is in order to help to decide how we could best manage it. So chronic pain actually is pain that persists for longer than 3 months. Not only is the pain the issue, but its effect on your entire function and quality of life. It causes emotional distress. It can cause functional disability, and most importantly, interferes with our activities of daily living and the things that make us feel human and normal, and obviously then has great impact on our mood. And as Dr. Bolton mentioned earlier, it is a very common condition. 20% of Canadians currently suffer from chronic pain, and so giving optimal management is going to be key in the success of really managing your patients. So people living with chronic pain often experience reduced quality of life and general health. They have decreased mental and emotional health, including increased worry, stress, anxiety, sadness, depression, anger, and frustration. People living with chronic pain are at increased risk of suicide. They have problems with cognitive functions, such as problems concentrating, processing speed, selective attention, executive function. They're more tired. They have sleep problems. They have reduced activities of daily living, including inability to do some of the things like that would allow them to participate in their community life. They are more likely to have school and work absences and reduced productivity, which affects their general mood and feelings of efficacy. They have increased disability and inactivity. They lose social connections and supports, and they use the healthcare system more. So certainly there are many reasons that we need to optimize our management of chronic pain patients. We know that managing chronic pain patients requires a holistic approach. It involves not only the pharmaceutical management, which is the main tool that us as frontline prescribers have at the tip of our fingertips, a prescription pad, but also there are psychological and physical modalities and education of the patient on prevention and understanding what chronic pain is and how to focus on function and getting them back to a better quality of life. So it's really important that we not only use that one tool of a prescription pad to manage a problem that's much more complicated than that. So if we go back to our case and remember Ed and see if we can figure out how we might use this chronic pain tool that we have all been working diligently on. So this tool assists us in the development of an individualized evidence-based treatment plan while using its interactive platform. We want people to be able to have at their fingertips not only a prescription pad, but also some education and some materials all collated in one area in order to help make it easier for you to do all of the frontline management things to do for chronic pain before referring on to a clinic. This pathway is organized into sections: prevention, assessment, risk management, risk factors and management. And you can see at a glance here that if you take a look at a particular patient like Ed, there are probably some areas in there that we could individualize this program or this plan for Ed's chronic pain. So we know he has an arthritis diagnosis, and there's some physical activity resources that we'll talk about in a bit. We know he is an obese patient, so there are some nutrition resources, as well as sleep resources for his sleep disturbance. So you can see it's all put together in one location for you, and it's interactive, clickable, and gives you the resources that you need. In terms of when you have a new patient with chronic pain or a patient with ongoing chronic pain that you are specifically looking at that issue, you do need to do a comprehensive history, including a functional status. There is a great tool called the Brief Pain Inventory, which can be used. And you can see it's highlighted there, and this can help you to get not only the pain issues, but also how it's affecting function, and can give you really good ideas about how to individualize and goalify the patient towards functional goals that matter to them. You do need to perform a physical exam and possibly arrange for special tests. It is important to understand that often with chronic pain, patients have had a very fulsome workup or they've had a lot of tests, but they don't really didn't make a lot of change in terms of their management. So yes, we want to make sure we understand the pain and differentiate pain and suffering, the subjective experience of it, but we functionally they're not able to do, and what imaging and or testing might help us to decide further with that and not order testing for the sake of testing. It's important to understand that in chronic pain, success isn't necessarily taking the pain and making it completely go away, but actually instead of focusing on a pain scale from 0 to 10, focus on a functional improvement, which is going to give quality of life improvements. It's also important when you are doing an assessment of a patient that you screen for co-founders, you rule out red flags and other comorbidities. So the pain pathway does have a nice section there that runs through the red flags that you can tick through, and also has some important other aspects of the person's total health that might help you to understand the patient and make a plan that's individualized to them. For example, patients who have childhood trauma, certainly it's important that you know that, understand it, and link them to appropriate services for that, and understand how this may impact their perception of their pain and how they manage their pain and their risk factors for other problems, for example, substance use disorder. Patients with chronic pain often have a mental health diagnosis. It's a very common comorbidity, but clearly having a mental health diagnosis or a substance use disorder are also important things to know about the patient, because it will help you individualize the plan. And there's some great tools here that can help you to screen and pick up on any of those comorbidities and help to individualize for the patient. So what did we learn after we we did this full comprehensive assessment of Ed. Well, we know now that he has hypertension, coronary disease, and had an MI with a stent years ago. So those are his comorbidities that make him, aside from his age, not a great surgical candidate. We know he does have a depression and has been reluctant to take antidepressants in the past, and that he had his knees replaced 10 years ago because of his osteoarthritis. We want to know what medications he's been optimized on at this time. So he's on ramipril, hydrochlorothiazide, aspirin, acetaminophen, ibuprofen as needed, glucosamine, chondroitin, gabapentin, and a fentanyl patch. The fentanyl patch dose is 75 micrograms per hour, which is about 300 milligrams morphine equivalent a day. And the gabapentin dose is 900 milligrams PO 3 times daily, which will come up later, so that's why I'm highlighting it. When you examine him, you can see he has an obese body habitus, and he was screened for sleep apnea with a high stop-bang score. He mobilizes with a cane and has an antalgic gait when he walks. And you can see the changes of osteoarthritis in his knees, but no neuropathic type pain and or sensations aside from that. So in terms of managing, again, we really want to emphasize that beyond the prescription pad, there are many other things that can help in the management of a patient with chronic pain. And we do need to use this integrated multimodal care approach if we want to optimize pain management. And it can be very frustrating and overwhelming to be in an office by yourself without a full team to try to manage all of these aspects of someone's pain management, but we do hope that these tools will help you to, number one, have some additional tools that are right in your office, and number two, be able to see some clear places to send people to optimize the other parts of the care. So, and we also have to understand that patients, because of understanding of pain and what it is, will initially sometimes struggle with prescriptions of active strategies. And so a lot of education may be needed initially in order to get those, and we need to honor that passive strategies also have value, particularly combined with psychological interventions. So what can we do about Ed? If we think of chronic pain with the 4 Ps of that we know are the full multidisciplinary approach, we can optimize care specifically for Ed. We have, from a psychological perspective, we know that Ed has depression and that he has not been open to pain medications in the past. Certainly, we can use this chronic pain pathway to look for a directory to find Ed a counselor so that he can work towards some of his, working through some of his ideas around pain and also just managing his mood and using those supports and structures that you can use from cognitive behavioral therapy through counseling. In terms of physical, because of Ed's osteoarthritis, certainly an exercise prescription can help him stay mobile. And there's good evidence that if a physician provides a specific exercise prescription, patients are much more likely to engage in exercise than if we just tell them go out and exercise and we don't give them some clear direction. So this exercise prescription noted here is a great little tool that can help you really individualize this exercise plan, understand Ed and what he is comfortable doing, and building an exercise program for him that he's likely to succeed at doing. In terms of prevention, clearly with his high stop-bang score, he does likely have sleep apnea, and certainly the Sleep Disorder Center is linked there, as well as there are several outpatient facilities that can optimize care of patients with sleep apnea. And then finally, we can take a look at his medications and see if there is any opportunity there to optimize those. So in the pathway, it goes through the different types of medications and also focuses on the different types of pain. It is important to note in Ed's situation that he has what we call nociceptive pain. He doesn't have neuropathic pain, so in reviewing his medications, there is opportunities there to maybe not only downsize his opioid morphine equivalent, but also to use medications that are specific for nociceptive pain.
So let me tell you, Dr. Liskowicz is about the best family physician that I've had in a long time, and she now is running into a little bit of challenges with Ed and thinks that it's about time, despite all of the efforts that have been made, to consider a referral to a interdisciplinary pain clinic. Now, she has set up Ed with a psychologist to help treat his depression, which is much better controlled with structured therapy than it was previously. As mentioned, through her referral to the sleep clinic, he now has appropriate treatment of his sleep disorder breathing, and in particular with his obstructive sleep apnea. He is compliant with his CPAP device. One of the common talks that I give to patients pretty much on a daily basis is pain, sleep, and mood, they're three bad bedmates. So if you don't treat all three at the same time, you're going to often be spinning your wheels. And I think this document really tries to highlight that, and the care that Dr. Liskowicz has done on our mock patient here has been quite beneficial. So through these efforts, we've also been able to optimize some of the medication based on the suggestions provided through this document. There has been a deprescribing of gabapentin, as there is no neuropathic component. So for this, we're probably just doing more harm than any good. With no neuropathic component, likely all we're doing is creating a situation where we're increasing a central depressant and likely just worsening his obstructive sleep apnea. There has been a opiate rotation to better comply with the 2017 National Opiate Prescribing Guidelines. And the medication that Dr. Liskowicz chose through this document, which is 100% appropriate, would be a rotation to morphine Cadian. There was some morphine statics that were used to the bridge, but now there is a final dose of morphine Cadian at 60 milligrams daily. But she's still running into some challenges. As we mentioned, functional is key here. So still running into some challenges with implementing, getting buy-in with the exercise program that she prescribed to Ed here, because he has quite a great deal of fear associated with activity. He's scared that he's going to do more damage to his knees. This is a specific condition called kinesiophobia, and this is where there's an opportunity, I think, for the more specialized clinics to help out. So what kind of clinics can we actually reach out to? So it depends on the kind of nuances of where the challenges are. So some of the clinics that are of note that has access in Regina in particular, this is not an exhaustive list, but it is part of the pathway for your perusal. Physiatry can be very beneficial, and in fact, they may actually be quite helpful in a situation like this. The MAC IOPS program, that is a pharmacy-led clinic by Derek Jorgensen, a pharmacist in Saskatoon, has very good virtual care assessments, and they are very user-friendly for those patients that are living outside of Saskatoon. They are exceptionally good at any kind of medication optimization. As mentioned, they are a pharmacist-led clinic. And then, of course, the clinic that I'm currently director at, the Regina Chronic Pain Clinic. We have lots of tools and allied health professionals at our disposal. So she does decide to refer to the Regina Chronic Pain Clinic. I was the MRP that was in charge of this, do a full assessment, and do find that there is some opportunities for care advancement for Ed. Now, interestingly, the knee is particularly amenable, even in a post-operative setting, for total knee replacements, to do what we call a denervation procedure, which is just a fancy word of saying that we burn the nerves that supply sensation to the knee while maintaining full functional ability. Now, this will improve pain quality, but also through this can help address probably the more driving factor in the barrier that Ed is facing with his kinesiophobia. Through this, what we would do is we would get the procedure above performed, And then as soon as that's performed and he does have a decrease in his pain level, we'll address the bit of the elephant in the room as far as the kinesiophobia and refer to our internal movement therapist who will work a lot with the neural desensitization and just getting patients a bit more comfortable within their body, a bit more comfortable with gentle movement, which ultimately is going to have a functional improvement, but also an improvement on their overall health, which that is a typical story that goes hand in hand with pain. As highlighted earlier in the talk, if you better treat pain, you're going to better treat the patient's overall health status. And we were able to do that with some success. So hopefully that mock case was useful. And now I think we have some time for questions. Thank you for listening.